You're listening to ReachMD, and this is Dr. Alan Brown. Today's show is Lipid Illumination, sponsored by the National Lipid Association. I'm your host today, and with me is Dr. Ben Ansell, Professor of Medicine and Cardiology at UCLA in Los Angeles and co-director of the Cholesterol and Hypertension Management Program at UCLA. Dr. Ansell is going to discuss the latest trials regarding attempts to raise HDL, including a recent study on a CETP inhibitor called dal-OUTCOMES, as well as the AIM-HIGH trial with the addition of nicotinic acid to baseline statin therapy. And then based on the results of those studies, what his view is of the focus on HDL in the coming years. So Ben, thank you very much for joining us.
It's my pleasure, Alan. Thanks for having me.
So these are a couple of studies that have been disappointing to HDLophiles, I would say. We had a CETP inhibitor that raised HDL by 30%, but yet did not show a significant outcome benefit in the dal-OUTCOMES, and I'll let you go into more detail on that. And then we tried using niacin on top of statin therapy in patients at high risk with established coronary disease in the AIM-HIGH trial, and also those results were somewhat disappointing. So if you could, Ben, tell us a little bit about these trials, how they were designed, what types of patients we were looking at, and then what you think the implications would be.
Well, I'll start with the AIM-HIGH trial. It was presented and published first. This is a trial, I think, that asked a very specific question, and it's been interpreted in a lot of ways. But the question I think that is most relevant that came out of that trial is whether the incremental increase in HDL cholesterol that is associated with extended-release niacin offers additional therapeutic advantage above and beyond what is fairly optimized LDL treatment in patients with coronary disease and low HDL cholesterol. It wasn't so much about the efficacy of niacin in raising HDL cholesterol or lowering LDL cholesterol, or even whether niacin has the ability to prevent coronary events. So those things had been, I think, previously shown and fairly convincingly in previous trials. But there was always a lingering question about whether the benefits of niacin would be above and beyond that with statin therapy, or whether they were a result of the LDL lowering or other atherogenic lipid lowering effects of niacin, or whether the HDL cholesterol increase was meaningful. This trial was a large trial in that it included an adequate number of patients, at least by design, to answer the question of whether the therapy would provide additional advantage. However, as I think most of the audience probably knows, the trial was stopped early, which created some questions about its power. But to go through just the results briefly, it was a trial in which patients were treated with background statin therapy, in this case simvastatin, and then that therapy was optimized to the maximal dose of simvastatin, or additionally possibly the addition of ezetimibe to get patients' LDLs down to the 70 milligram per deciliter goal that's been established for these types of very high-risk patients. And the patients who were in the niacin arm got the background therapy of simvastatin with the addition of niacin, and then, if needed, additional LDL lowering beyond that. So that the LDL lowering between the two arms, as complicated as the comparison was actually fairly similar. And so the comparison became the HDL cholesterol raising with one side versus the other. And I say that because both sides actually had an increase in HDL cholesterol. Obviously, the group that got the nicotinic acid had a significant increase in HDL cholesterol, in this case about 25% from baseline, but so too did the group that got the monotherapy, as it was called, the therapy of just simvastatin and possibly ezetimibe on top of that, had almost a 10% increase in HDL cholesterol because it received a dummy version of niacin, a low dose of nicotinic acid, immediate release, so that patients wouldn't be unblinded to being in a placebo against active niacin. And it turns out that does raise HDL cholesterol a bit. But whether the patients were in the group that got that very low dose of nicotinic acid or the more conventional 2-gram dose of nicotinic acid, there was no difference in the primary endpoint in this study, which was a composite of vascular events. And as such, after about 3 years, the patients in this trial were stopped because of pre-specified termination criteria and what was felt to be a futile outcome. I think the estimate was something like a 1 in 10,000 chance that there would be a positive outcome. And with the confidence intervals, they were able to exclude all but perhaps a 10% incremental benefit to that roughly 15% difference in HDL cholesterol, just even with the trial stopping early. But because it was stopped early, the trial did lack adequate power to make that distinction. Now, I think power issues aside, it obviously was very disappointing because this was the group of patients that most of us felt was probably the most appropriate for combination therapy with statins and niacin. And the fact that there was nothing to hold our hat upon to look to benefit these patients by that incremental increase in HDL was certainly, I think, a surprise and disappointing. On the other hand, these are patients who were very, very well treated, and there hadn't really been a study like this before, and there's a reason we do these clinical trials, and it's not because we know the outcomes a priori. So I think it was an important question. It's not really in many ways the clinical question that many of us face, which is if we have a patient and their HDL remains low after statin therapy, would they benefit from adding on niacin? And that question may be better answered by the HPS2 Thrive study, which is expected to be presented either later this year or the beginning of next year, in which patients are just simply given a background of statin therapy in a similar population with the addition of nicotinic acid extended release with laropiprant, a flush blocker, or placebo. Now, that won't answer the question of whether it's the HDL raise that is associated with any potential outcome difference, just whether the use of nicotinic acid makes a difference. But it is in some ways more clinically relevant, and there are something like 20,000 patients in that study, so I expect it will be adequately powered to make that distinction. But in the meantime, we have, I think, one study here which, power issues notwithstanding, certainly is a kink in the armor of the HDL hypothesis that most of us assumed, at least with niacin, would probably be adequately answered. The second trial, which was looking at a completely different mechanism, CETP inhibition, really was trying to ask a very different question, which is, will the use of a CETP inhibitor and the associated change in lipids with dalcetrapib, mostly an increase in HDL cholesterol, a relatively modest increase compared with the other CETP inhibitors, would that result in an outcome difference, in this case in very high-risk acute coronary syndrome patients? And there was none, and again, the trial was stopped early. In fact, the development of that compound was discontinued as a result of that. There are many more questions about CETP inhibition and its potential impact on cardiovascular risk. It's obviously not the first drug to fail in this area. We had torcetrapib about 5 years ago, which failed. Most people believe because of off-target effects, but certainly those off-target effects, which included aldosterone-like increase in blood pressure, among others, didn't offset any potential benefits, if there were any, in a substantial increase in HDL cholesterol and decrease in LDL cholesterol. And there remain questions about the nature and the function of the HDL that was produced by that compound, and perhaps even dalcetrapib too. But you were a dalcetrapib investigator. I imagine it was pretty disappointing for you as well, Alan.
Yes, and this brings up a couple of questions that I want to ask you. So, for those just tuning in, you're listening to ReachMD. I'm Dr. Alan Brown, and this is Lipid Illuminations. I'm speaking today with Dr. Ben Ansell, Professor of Medicine and Cardiology at UCLA in Los Angeles and co-director of the Cholesterol and Hypertension Management Program at UCLA. So thank you, Ben, for that really insightful discussion about AIM High, and also your discussion about the DAL-HEART study, which was a study to look at cardiovascular outcomes with dalcetrapib on top of a baseline statin therapy. I want to ask you a clinical question as the director of a lipid clinic. I really was hoping that AIM High was going to be looking at people that needed to be treated the way the NCEP guidelines said they needed to be treated. In other words, that you treat their LDL to target, and in this group, though it isn't established as a guideline, we all kind of accept 70 as the right target for people with established coronary disease. And then, if their triglycerides remained above 200, where their non-HDL was elevated, then you would add additional therapy to treat their non-HDL. So it was interesting to me that in AIM High, the average non-HDL was actually pretty much at target, 105. The LDL was at goal. So NCEP would have said you don't need to add anything to treat those people despite their low HDL. But it turned out they really didn't have very many patients with high triglycerides, so they couldn't take a look to see if would adding niacin help if you were treating them according to the current NCEP recommendations. So I wonder if you have any thought on that. I mean, I think it answered that if you have isolated low HDL, but your LDL is at target and your non-HDL is at target, you're probably done, which is what NCEP says, right?
Well, I think, guidelines are guidelines. In this case, NCEP, to be fair to what's, a nameless, voiceless, panel that collectively issues a statement, there wasn't any data to make an argument for additional treatment in that group. There certainly was fairly convincing evidence, mostly from the Treat to New Target study, that there remained a significant amount of residual risk, even getting LDL and non-HDL levels down in that population, that the subgroup of patients who remain with a low HDL cholesterol, I believe in that trial in the lowest two quintiles, had substantially elevated risk relative to the rest of the cohort. But we just haven't had, aside from niacin, any convincing way to be able to do that. And it was a tertiary recommendation to potentially raise HDL cholesterol in that group.
So do you think there are any implications about changing the use of adding either fenofibrate or niacin when people do have a high residual non-HDL? Because this group did not, right? So this was treating people with just isolated low HDL. And I think some of our physician colleagues decided that we should just never use niacin or never use fenofibrate based on the ACCORD data. But it looked like, at least in ACCORD, that subgroup that had high triglycerides and high residual non-HDL were extremely close, if not clinically significant, depending on how you split hairs there. What do you think would have happened if they looked at people with high non-HDL on a statin with LDL at goal? Would that be an indication for using niacin?
I think on the basis of AIM High, we'd have to say no. And it hurts me to say that, as you term me an HDL file. I think that the ability of HDL raising, at least at that stage of coronary disease, against that backdrop of reduction in ApoB, doesn't seem to be very significant, at least with nicotinic acid in that population.
And do you think if they had triglycerides of 250 or 300 instead of under 200 and had a high non-HDL in a population like that?
I think there might have been more opportunity there. There's, I would suspect, have more LDL particles in that population that probably would have then arguably not been optimally treated. Obviously, we don't have the advantage of those types of data at this point with AIM High, but I suspect that if we are going to see a benefit, that would be the type of group that we would expect to see a benefit. And to your question about fenofibrate, or really, frankly, the fibrates in general, where they have shown benefits, it's almost exclusively been in that population with low HDL and concomitantly high non-HDL, high triglycerides, either in TOTO, such as the VA HIT trial, with Gemfibrozil, or in subgroup analyses. But I'm loath to make treatment recommendations about using agents when they're based upon subgroup analysis and trials that are overall neutral in their outcome, right. or even just based upon trends in that regard. I think the fibrates effect in a broader population, unfortunately, clearly isn't robust enough to be adequate to really show any kind of benefits in the broader population clinical trials thus far.
Yeah, we still need a clinical trial that's designed the way the guidelines tell us to treat patients, where they really enroll people who have high non-HDL and whose LDL is target. Those are the people that they say we should be going for our secondary target of non-HDL. And we've been pretty unsuccessful in getting a large group of patients who fit that set of criteria, despite the fact that it's a secondary target in our guidelines. And the AIM-HIGH population didn't have that group of patients. So it's a very interesting discussion, Ben. I want to thank you very much for really going into detail on both of these clinical trials, as well as a little bit about the background of HDL and its functionality. And thanks for joining us.
My pleasure.
Many thanks to our guest, Dr. Ben Ansell. We've been discussing the dalcetrapib trials, a new CETP inhibitor, as well as the AIM-HIGH trial with the addition of niacin on top of baseline statin therapy. I hope you found this discussion interesting. And there's many more things we need to learn about HDL, and we're looking forward to discussing further research in the future. Thank you for joining us.